asked questions. Now, before we start the webinar, I just want to do a little bit of housekeeping. If Sarah wants to share the yeah, so just for everybody to make sure that it goes well for you today, please note that this information is gathered from trusted sources and is accurate at the time of the webinar. It can be used as an aid, but never replaces your own clinical judgment. It is a recorded event, so you will be able to go in and review it when it's up on the website where I've just shown you where to find it. If you have any technical questions and need help, please use the chat function and ensure that you send it to hosts and panelists and not to everybody so it doesn't distract everybody. If you have any questions, if you go into the Q&A function, if you put your questions in there, anything that Dr. Sarah doesn't cover during her presentation, we'll address. Either we'll type in the answer or we'll let her answer it online live. And at the end, we're going to put an evaluation link into the chat function, so you'll be able to do an evaluation of today, and any suggestions that you have for future webinars is really always very helpful to us. So you can sit back with your cup of coffee and enjoy the webinar. There you are, Sarah.
Thanks a million, Louise, and thanks so much to everybody who's joining us today as we talk about the frequently asked questions that we get in cervical screening. So as you might imagine, there are a number of questions that come into us in CervicalCheck, and what we hope to do with this webinar is just to cover the main questions that come in, the most frequently asked ones, but also to encourage you to ask any questions that you do have, either in our chat function there, in our Q&A, or if other questions do come up for you, as Louise has very clearly shown there, a lot of the answers might be available already on the website, and we are always very open and willing to ask any questions that come into us via email or on the phone. So I suppose where do our queries come from? So who are the people who might be asking us questions? So what we know is that the different sections of CervicalCheck will receive queries both from the public, from participants, from women, and from sample takers, and from other parts of the program. So our primary care administration office have told us about all the questions that they get, our registration office, the call center, which is the free phone number that anybody can phone, looking for any queries in relation to cervical screening, and as well as at the info email, our screening training unit, so all of our trainers and training coordinators. The laboratory gets asked questions, and our colposcopy unit will often receive questions and also have questions to relay back. So these are where we try to gather all of the different queries that we're going to attempt to cover today, just to let you know that everybody who's involved might have a different perspective. So we're trying to, as much as possible, cover all of those different angles. So if we start with the types of questions that our administration colleagues and registration colleagues often receive, and one of the most common questions that they get, so when somebody is phoning up, their question is related to, is my test due if it's a woman who's inquiring, or is the patient or the woman who's in front of me, is her test due? And that would be maybe coming in from practice nurses, from GPs. So really, really common, and we really support people to find out whether a woman is eligible before you do the test. It is always going to be more useful for everybody if we are sure that she is eligible before the test is taken. So certainly one way of doing so is by phoning up, but we would strongly encourage you to think about the online version, and I'll go through that in a minute. Another commonly question that has been coming into the administration office would be a patient saying that she's been refused an appointment. Other difficulties that have arisen would be in relation to contract cessation. So that would be a GP or a clinically responsible doctor, CRD, resigning or retiring. A frequent source of queries is in relation to our hysterectomy data collection form, which is the form that needs to be filled in when somebody has had a hysterectomy. Another issue that causes trouble between colposcopy and primary care and the administration office would be in relation to a woman who's having a test taken while she's still under the care of colposcopy and she hasn't yet been discharged. Sometimes there can be issues to do with medical history being included on the form, so non-relevant medical history being included on the form, and then in relation to Failsafe. So we're going to go through all of these in a minute, just to give you a flavour of the types of questions that come in. The most common question into the call center, so this would be more often from patients, from women, from the public, and probably the top question that's coming into the call center since we've changed over to HPV screening would be query around my cells. Why aren't my cells being checked? I had abnormal cells before. If I've only had a HPV negative result, how do I know what's happening to my cells? So very, very common question that comes in. Another thing that has been occurring more recently, a lot of you will be aware that we have extended eligibility for some women who would have been removed from the program or have left the program around the age of 60 when we changed over to the primary HPV screening in March 2020. And they are now eligible. Every GP and clinically responsible doctor will have received correspondence in relation to how we have changed the eligibility. But what has unfortunately happened for some women is that they have received a letter to say, would you like to come in for a HPV test? But unfortunately that the GP hasn't been aware of the eligibility extension, hasn't perhaps checked the eligibility online for the woman, and then has been refused an appointment. So obviously we would be very keen that that wouldn't happen for a woman who has been invited. The other situation in which patients get refused an appointment and which can cause them distress would be if they're not a patient of the particular practice. And again, we'll talk about the what the contract and what the primary care standards say about offering an appointment to anybody who wants to make an appointment with your practice, even if they're not a regular patient of the practice. Some other issues that come in through the call center would be in relation to prolapse and pessaries, people wondering, could they have a screening test done if they have a prolapse or if they have a pessary in? I suppose the simple answer is if they're eligible for a screening test, they should have it done. Again, we know that there can be technical considerations around doing the test, but from the woman's perspective, yes, the answer is yes, if you're eligible for screening, you should have it done. Another issue would be women phoning up wondering about they've had a hysterectomy. And again, we'll talk a bit more about that. And then again, in relation to our maybe some of our participants over the age of 50 about the use of vaginal estrogen. So just to give you a flavour of what's been coming into the call centre over the past maybe 6 to 8 weeks or so. The questions that get asked of our screening training units, so all of our clinical trainers very commonly might be asked a question about a woman who's never been sexually active. Should she be screened? Why do I have to wait 3 calendar months to repeat a test? Talking about additional private screening, we know is quite a challenge within the primary care setting. And then the education obligations that have been introduced since the most recent contractual changes. So we'll discuss those as well. Laboratory doesn't tend to get a huge amount of queries, but what can happen is the GP or a practice nurse phoning up looking for results. So they might be phoning the laboratory office of CervicalCheck, but the advice is to contact the lab directly. So you should have those contact details. They are available on the website. And if you have a query about a particular result, just make direct contact with the lab. They'll be able to help you with that. Sometimes the recall recommendations for women who are pre or post transplant or are living with HIV, people can be a little bit unclear that you need to tick the box every single time she has a test. It doesn't follow on. So just if the box was ticked on the last test, it doesn't mean that the lab will be aware of her circumstances. So it's just an important thing to tick the box on the form each time a test goes in. And then colposcopy, and I have to admit these are my own inverted commas on the inappropriate referrals. We know that sometimes a referral can go to a place in secondary care and the recipient of the referral might feel it's not appropriate for that place. I suppose my suggestion around that is really getting to know your local referral pathways as well as you can. Thankfully, we do have a number of ambulatory gynae clinics coming on stream, and it might be that somebody that you would have sent to colposcopy in the past, it will now be seen through the ambulatory gynae route. So we know that in colposcopy clinics, sometimes they are redirecting referrals. And again, I would say that increased communication between secondary and primary care is often the thing that helps this the most. Colposcopy clinics are very keen to have the full test result attached to the form. As we know, for most colposcopy clinics, the form is still in a paper format. We are very much looking forward to electronic referral coming in for colposcopy, but the test result will still need to be attached electronically on the electronic form and then printed out and added into the paper form. If there is any clinical query regarding a discharge of a woman, the best thing to do is to contact the colposcopy unit, not to contact the central CervicalCheck number. And after a woman has been through colposcopy, there is an algorithm in relation to when she should have her next test due. The colposcopy clinics will be following that algorithm, and it is possible to find that algorithm on the website if you're not sure. But again, direct communication with the colposcopy unit would make the most sense in terms of working out the specific guidance and direction for your own patient or the woman that's in front of you. So we just go back a little bit to some of those questions that come into the administration and the registration offices in CervicalCheck. And as I say, the top one of those is eligibility, is the test due? And while phoning up is one way of finding out, I would strongly recommend that everybody would make it very much part of the routine of doing a screening test for any person that comes in, that you go to cervicalcheck.ie, you click on the section that says there's a little box right in the middle, and it says check if your cervical screening test is due. So you're going to be doing that for the woman, or maybe you've supported her to do that in advance. Sometimes some practices might send out a little SMS in advance if people are inquiring about having their cervical screening test done, and they'd send the link, and you can check it yourself. But basically all you need for the woman is her PPS number and her date of birth. So it is pretty straightforward. You just pop those things in, and then the website will either tell you that she is due, or they will say that when she will next be due. So very, very, very important, and really quite simple to do that, and probably a good bit quicker than maybe trying to phone in. So we would strongly encourage everybody to get familiar with that eligibility checker online. I mentioned the issue about patients being refused for an appointment if they're not a patient of the practice. And this is just a reminder to you that there is an entire document called the Standards for Quality Assurance in Cervical Screening in Primary Care. And when the CRDs sign up to the contract, and when sample takers are registered with CervicalCheck, we're all agreeing that we're going to adhere by these standards and guidance. And then so the eligibility requirement states that eligible women, including those who are not patients of the practice, should be facilitated. We know that practices are, full to new patients, that a lot of lists are closed. But what you're saying to the person who's asking for the test is, absolutely, you can come for your cervical screening test. Unfortunately, we're not able to provide you with any other service. And again, we know that can sometimes be a little bit of a difficulty, but as long as the reception staff, as long as the administration staff are very clear on this for a person in advance of them arriving for the test, that, we're happy to do your screening test here. And like that, if we're not able to take you on as a patient for your general medical needs, then that should be just made clear. But it is very important that a patient would not be refused, because, as I say, they have all of the information on the website, and the information leaflets that women will get is that you can make an appointment at any registered practice. And again, all of those are available online. If you are going to cease the contract, or if this CRD that you're working with is going to cease their contract, they do need to give 6 weeks notice to the administration and registration departments in CervicalCheck. So that would be the case if you're resigning from the contract, retiring from the practice. Very important that no screening tests are taken after the time of indicating that you are going to resign or retire. That's to make sure that no test results are left hanging, basically. And there has been, obviously, as we know, again, quite a few changes in terms of practices, maybe people, older GPs retiring, younger GPs choosing different lives. And it's really important that the women who have been screened are, reach the end of the screening journey before the clinically responsible doctor heads off to the beach somewhere. So very important, the 6 weeks notice. Hysterectomy data collection form. And again, we know that this can sometimes cause a little bit of confusion. If a person has had a total hysterectomy with normal histology, so their womb and cervix have been removed, and there is normal histology, so there is no evidence of any CIN and any cell changes on the histology, then that woman can be safely removed from the cervical screening register and doesn't require any further screening. And that's what the hysterectomy data collection form is for. So filling in the details on that, the GP signing the form to say that this woman does no longer requires screening, is really, really helpful, because then we're ensuring that people who don't need to be screened aren't getting call letters coming in. If a woman is attending colposcopy and she comes to primary care for a test, so let's say she's attending colposcopy and they say, come back to us in 6 months' time, but in fact, it doesn't really suit her to do that, and she arrives into her practice, or sometimes it can even happen that she mightn't even have mentioned that she has been at colposcopy. What can happen there is if she hasn't been discharged from the colposcopy unit, on the cervical screening register, so the database that's kind of keeping track of everybody, the register is unable to then sort of determine her next test because it is coming in under, she's still being registered as being in under colposcopy. So it's a little bit tricky when this happens. It can be quite confusing from the point of view of the follow-up of the patient. And so we do recommend as much as possible that a woman would be discharged from colposcopy before she would return to having her tests done in primary care. If she has other particular issues or reasons why it's not possible for her to attend the colposcopy unit, again, very important to communicate with the colposcopy unit. If she says to you, I'm never, I'm not going to go back there, then she can be, discharged, and a record can be made of her choice around that. But it's just floating between colposcopy and primary care can sometimes cause difficulties in relation to her next recall, and it could happen that she might miss the invitation for her next test. The medical history, sometimes, particularly when the forms are being autofilled, from your practice software, it can end up with a big long list of all her previous medical history. And what can happen then is that sometimes that needs to be manually removed, because obviously in terms of data collection, GDPR, all of those kinds of things, it is only clinically relevant information that CervicalCheck kind of has a right to hold. So just having a quick check on the form to make sure that anything is going into the medical history is relevant, as in, so presumably, related to gynecology history or somebody who's living with HIV, those kinds of things. So again, these would be some of the challenges that our administration and registration colleagues have brought to our attention. Just focusing very much down on the Failsafe system. And again, this would be something that our primary care coordination colleagues would find can cause issues. The CervicalCheck screening register has built into it these little triggers that happen if somebody doesn't attend. So if a woman is being identified as being at higher risk, we really want her to come and have her next test or her repeat test, or we want her to go to colposcopy. And in order to make sure that she doesn't fall through the cracks, these fail-safe measures are built into the cervical screening register. That's what CSR means up there. And so if somebody has received a result which said repeat the test again after 3 months because the result was unsatisfactory or indeterminate, so we know that this can happen, that somebody comes for their test, we're delighted they came, but unfortunately the result is indeterminate, so we say to her to come back in 3 calendar months. Or if a referral to colposcopy has come back on the result, so the recommendation for referral to colposcopy has come in on a result, but the woman hasn't attended, or if she doesn't attend for her first test after discharge from colposcopy, or if she doesn't come for her 12-month test if she's had a HPV positive, cytology negative. In all of those situations, if she doesn't attend within 2 months, if the test doesn't arrive at the lab or the notification doesn't come from the colposcopy clinic, then that triggers this fail-safe mechanism on the register, which means then that she gets notified, the GP gets notified, and the process is put in place to really try and encourage her and support her to come for this next step test. So why is it important? And again, we know that sometimes the GP or the general practice nurse might have contacted the woman themselves, that they might have their own protocol, their own register in the practice, and they might be kind of on top of it. They might be saying, oh, I know she's coming, she's away in Australia and she's going to be back next month, but she's said she's going to come in then. And so the practice itself might know all that and might be documented on the practice software, but it's really important that CervicalCheck knows as well, because as I say, it just helps to make sure that she's back on the appropriate recall and that she receives her next invite. So we know that we get these forms out from CervicalCheck with the fail-safe on it. So, it's a notification to say that she hasn't attended within 2 months. And so what happens is, I'm just going to go forward. So you get a form that looks a little bit like this, that says, repeat screening test recommended, that she was recommended for a repeat screening test and it's now overdue. So when this form comes into the practice, comes into the GP or the CRD, there are two choices. You can either go online to fill in the Failsafe. And again, this is through CervicalCheck.ie and the health professionals tab. And then the Failsafe request is down here, sorry, at the bottom. And you just put in the doctor or clinic ID, so the MCRN for primary care practices, or the clinic ID in clinics, and then the woman's CSP ID. And you submit, and then it follows along. You go through the recommended screens and fill in all of her details. Once you get to the end of that and you submit them, all of that comes back into the register. And like that, if it's been, something on it that she's changed address, or that she is pregnant, or there's, some other reason, then that's great. Then the register knows, and that's been recorded, and it can update according to what's been filled in. If doing it online doesn't suit for whatever reason, as I say, there is the paper form. This is how it comes into the practice. And again, you're filling in, yes, she has attended, or no, she hasn't, and giving the reason. She's pregnant, and this is her estimated due date, or her address has changed. And so you're filling all of that in, doctor's signature at the end, stamp, and posting it back. So it doesn't really matter which one you choose. Some people might like the efficiency and the speed of doing it online, saving on the post and all of the effort that goes with it. But either way, it's really important that when these come into the practice, that they are acted on. Even if you know what's happening with the woman, it's really important to let CervicalCheck know what's happening. So many questions that we have will be in relation to, what do we do with this woman? What do we do with that woman? What happens if she gets this result, that result? And just that reminder, we say this a lot, and I know you're probably sick of us saying it, but the eligibility framework, again, available on the website, is probably the most useful piece of information in relation to that. It goes through the eligibility in terms of the age ranges. It goes through the intervals. It goes through the special circumstances in terms of somebody coming, being discharged from colposcopy, somebody who's had a hysterectomy, somebody who's living with HIV, renal failure, radiotherapy, etc. So, a lot of your questions should hopefully be answered by this quite simple table. And this will cover, those circumstances where a person is not eligible. So when they're under the age of 25, when they're not due, when they're outside the upper limit of age range, etc. Little reminder here again about the immunosuppression medication. We know that this can sometimes cause confusion. A person who's using immunosuppressant medication for any reason, whether it's arthritis, whether it's skin conditions, psoriasis, multiple sclerosis, any of those things, their recommendation is still the same. They do not need increased HPV screening. So if they're HPV negative, their risk is the same as everybody else. If they're HPV positive, obviously they will follow that pathway. So again, coming back to those questions coming into the call center, and these would be the questions coming in from women and from the public, and what we mentioned about the what about my cells question. And as time goes on, we move further forward from 2020, when HPV screening was introduced. It may be that fewer and fewer people are sort of thinking in that frame of mind, but it is still very useful to think about this image that we would use in relation to comparing HPV testing and cytology testing, or looking at the cells. And so we remind everybody that if you have a room full of 1,000 women, then their risk of having precancerous changes is that 20 of those, that 1,000 are likely to have precancerous changes, or do have precancerous changes. So how do we find them? And using the old cytology test, we would have found 15 out of those 20. So looking at cells on their own is 75% successful in terms of finding women with precancerous changes. Whereas when we use HPV, we'll find 18 out of those 20. So HPV is a better test for identifying precancerous changes. The reason for that is because of the influence of HPV on the cells. So they'd be saying, well, how do you know my cells have precancerous changes? You've only checked for HPV. What we know is that cells do all sorts of funny things by themselves, and they can sometimes look different. And in the past, somebody might have been told that they had abnormal cells, and might even have had a treatment, and people would have been saying, well, I had these abnormal cells. But what we know now is that in the absence of HPV, If there's no HPV infection, then those cells are very likely to regress, to go back to normal by themselves without any treatment. Whereas if the HPV is present, then we do know that they're at higher risk then of oncogenic change, of changing into cancer. So the presence or absence of HPV is the thing that gives us reassurance or not. If you don't have HPV, your chances of progressing to cervical cancer, HPV-related cervical cancer, which is more than 90% of them, is very, very small. And it's really important, again, to encourage, conversations around this with women who are not sure, who are, maybe a little bit suspicious or have a lack of confidence in the test. If you don't have HPV, you're really in a very, very low risk category. If you do have HPV, then yes, your cells could change, and we will look at them. We will look at them under the microscope, and we will look at them in colposcopy if necessary. So again, the questions that coming into our screening training unit in terms of screening a woman who's never been sexually active, and we know this can come up quite a lot. What we would say is that we know that HPV is vast majority of the time is transmitted through sexual contact. That doesn't have to be penetrative sex. That is not necessarily heterosexual sex. So that is not necessarily a man and a woman having full penetrative sex. Any kind of skin-to-skin contact of the genital area can transmit HPV. If we think about it, we know that condoms are, not brilliant at preventing HPV, and that's because it is in relation to that skin-to-skin, genital contact, as opposed to the act of penetrative sex that can result in HPV transmission. So when somebody says they haven't ever been sexually active, it is very important to explore that potentially with them, obviously in a sensitive way, what they mean by that. And a lot of times people might mean that they've never had penetrative sex with a man. This is very important when we think about people in lesbian relationships, so women who would have sex with women, because again, they are equally at risk as anybody else in the population. Somebody who's never had any kind of sexual contact of any description might still choose to have a cervical screening test done, and that would be their choice to have that done. So it is not a blanket no, and again, it does take a very clear exploration in terms of what people mean about never having been sexually active. And again, unfortunately, as we know, sometimes people will have had sexual contact that was non-consensual. It might be an extremely difficult thing for them to talk about. Could have happened as a child, as a young adult, and they may not be in a position to be able to mention it. So we can never make assumptions about somebody's previous exposure. The question coming up about the waiting the 3 calendar months. So we're going to come to that and also in relation to additional private screening. So in about the private screening tests, so these would be, I suppose, what we would call private smears. And we know that this can come up quite a lot. People will come in and they'll say, well, I'm not due my next screening test for 5 years, this is a disgrace, and then coming back to the conversation around the cells, and they will request to have a private screening test done. And again, what we know about private screening tests is that in general, they're unlikely to be of extra benefit to a woman who has had her HPV test done. Vast majority of the time, it'll be somebody whose result has come back HPV negative, and then they haven't had their cells checked. And this is why they're asking for the test. But really trying to reinforce that fact that if there's no HPV, then your risk of a screenable cancer is really, really low. We know that there are some cervical cancers that can't be screened for; they never could be. And while they're rare, they do exist. And there are a number of other cancers that we also can't screen for, but that we try our best to detect at an early stage through very being vigilant around symptoms and being mindful of red flag symptoms in terms of intermenstrual bleeding, postcoital bleeding, etc. So, if a woman is asking for a private test, one of the first questions to find out is she having symptoms? Is that's why she's asking? And sometimes people will choose to say, I'd like to have a screening test, rather than to say, I've been having symptoms. If she is having symptoms, a screening test is not the correct test. It's not diagnostic. It is not the right route to go down. It can be a false reassurance. Just mentioning at the bottom there, a negative screening test can sometimes falsely reassure a woman. If she is under the age of 25, we know that it is extremely common to have abnormal cell changes under this age, but actually cervical cancer is extremely uncommon. And what can happen is that somebody under the age of 25 will have a cytology test done. It says, yes, there are some abnormal cells. Sorry, that didn't mean to go forward. And it could result then in them having a colposcopy referral, potentially having something like a LETS procedure or an invasive type procedure, which can then subsequently have consequences in terms of miscarriage, preterm birth, etc. So doing screening tests in women under the age of 25 is very, very unlikely to be of benefit and is more likely to be of risk. The other potential problem with a non-programmed screening test is that CervicalCheck won't have that data in her screening history. So it won't be incorporated, it won't be included on her record on the cervical screening register. I hope you can all hear me there. My internet might be going funny. And it's also a source of possible conflicting results. So it could happen that she gets one result from CervicalCheck, a different result from her private screening test. And again, obviously that's, undermines her confidence, is difficult. So we know that this is a problem that can come up, but we strongly encourage, conversations around the validity, the positive predictive value of a negative HPV test, as in if your test is HPV negative, then your risk is very, very small. Just going back to why we need to wait 3 calendar months, and these are the circumstances that we'd be talking about where you need to wait 3 calendar months after pregnancy. Breastfeeding doesn't affect that change, so it's still 3 calendar months after delivery, but the test can be a little bit more uncomfortable due to vaginal dryness. Any repeat test needs to wait 3 calendar months, and following an IUS insertion or any other cervical manipulation, you need to wait 3 calendar months. The reason is for pregnancy and breastfeeding is for the hormonal changes in relation to pregnancy to sort of return to normal, so that the cell changes that happen during pregnancy, you need to give it 3 calendar months before they can go back to normal, so that if she does turn out to be HPV positive and her cells are looked at, that the cytologist is able to inspect these cells and they are in their normal non-pregnant state. For the repeat tests, again, it's if the screening test has already been taken, or if there's been manipulation of the cervix through, inserting a Mirena or a Kylina, the use of a tenaculum. Many of those things on the cervix is going to disrupt the cells. And so for the same reason, we're saying to wait 3 calendar months to ensure that the cells are back to normal again, in order for the test to be valid. Sorry, now I might have missed through a couple there. I'm just going to go back to this one. Sorry, this is the how do I fulfill the education obligations? So again, Louise has already mentioned in relation to all of our webinars that are available, but most importantly for our education platform. So again, through the NSS Resources.ie platform, where you're able to access our CervicalCheck in practice module, which every sample taker, when they register, is obliged to complete. And we would, in the recent contract, the education obligations say that you need to have completed a accredited module, including the CervicalCheck and practice module, once every 3 years. And again, that is a change since last August. And just a reminder to people that that is the case for everybody who's participating in cervical screening. So what we might do is I might come out of the share there and just come back to Louise and Rachel, and hopefully you've all been able to hear me there with that. Rachel, you're sharing there now, are you?
Yeah. No, I don't think.
Yeah, I was just thinking we might go into NSS Resources. Can you see the page that I'm seeing? I can see my Comer on it.
No, you were sharing, but it's gone off it again, Rachel. If you share again.
Well, I'll just do this very quickly. It's just important because some people don't realize that we have a really good e-learning platform.
When we're waiting for Rachel, there was actually a question there that I could put to Sarah. I don't know will you actually have the stat on this, but I might just explain again the HPV. The question is, if a woman has ever had HPV, what is her overall risk of a cervical cancer?
Yep. So I suppose just, you know, a reminder to everybody that 80% of us, 8 out of 10 of us will have had HPV at some point in our lives. Most of us won't know it. And particularly because obviously we weren't testing for HPV unless in particular circumstances before 2020. So it's very common that somebody will say, well, I never had HPV before. And we will say, well, you know, we wouldn't have necessarily known whether you did or not. But most of us, it's more common that you will have had HPV than that you won't. And a reminder to everybody that it's the persistence of HPV that causes trouble. HPV itself is not a problem. The vast majority of 12 to 24 months. And, you know, again, there's more than 100 different subtypes. So I suppose the immunology of it would say that you could have one subtype, become immune to that. You won't necessarily be immune to another subtype. Although there's still, you know, there's still quite a bit of research around that. Not all subtypes are oncogenic. Not all subtypes are high risk. The two subtypes that are most implicated in cervical cancer are HPV 16 and 18. And so what can happen is that you could have had HPV in the past, not know about it. But if your HPV is persistent, and we know that by testing you once and then testing you, if you're positive, testing you 12 months later, and that is when the risk element comes in. So in fact, having had HPV in the past can potentially protect you from getting that type of HPV again in the future. So your overall risk, again, a reminder to everybody, the overall risk of cervical cancer. So the rate of cervical cancer in Ireland at the moment is just under 11 per 100,000, just around 300 cases of cervical cancer per year. That's quite a bit smaller than the other cancers, we'll say like breast cancer, lung cancer, bowel cancer. It does affect a younger cohort of women, but cervical cancer as an entity isn't exceptionally common. It's relatively rare compared to some of the other cancers we deal with.
We have another question there, but I think it would be better when Rachel is sharing, because this is really worthwhile. If Rachel goes and shows us the NSS resource, and then I'll go back then to the other two questions, if that's all right with you, Rachel.
Perfect, thanks a million. Yeah. I just posted the survey link there, so if anybody, actually before I put in my, if you want to fill out the survey from today's webinar, it'd be great. But before I put in my password, I'm going to show you to come down here to create a new account, because it's really important when you're going to NSS Resources. So go into your tab page, www.nssresources.ie. It's really important that you put in your MCRN or your MBI. Make sure it's correct, because if it's not correct, we won't be able to transfer to make sure on the other side of your CSR that you have completed the associated clinical update. So we'll be emailing you saying, actually, you're not up to date, because your contract currently states you must complete a clinical update every 3 years. And you must have your email that you use and your title. So make sure all of them are correct. So once you have all your details, log in. And click on CervicalCheck. Hope this is moving for you. And you can see the page here. If you're just wondering, if you have any questions in relation to how you register with CervicalCheck, pop into this tab. The next tab is about your education requirements. If you need to complete a cervical screening education program, we all know that sample taking is an extension to your scope of practice for nurses and midwives. So if you need to complete a program, the 7 new workshops that have been advertised yesterday around the country for 2024, it tells you all about the application process. The theoretical content is entirely online. So if you click here, it brings you into your 8 presentations that you must complete. So the clinical updates, you click in here, and it tells you your obligations if you want to become a clinical supervisor to support your learnings in relation to clinical supervisor. You need to complete two clinical updates, and then we have 3 clinical updates here. So if you work in primary care, you click on this one for your CervicalCheck in practice. If you click on this one, it brings you into your non-primary care. So if you work in colposcopy, SATU, gynae, ambulatory gynae, that area, the gum clinic, you can click on this one. And then we also have cervix visual assessment guide and recognizing the suspicious cervix. We've also that clinical update. So click on there, and it'll bring you into your appropriate clinical update. And as I said, you must complete one of them every 3 years. If you need to register for any of the clinical updates, click on this box. We have our resources. We have a lot of resources. It should be live next week, but still under construction, as you see there. So that's our NSS resource. Make sure you have an account. I'm going to stop sharing, but it's really important you go in and have an account and make sure you complete your requirements there.
Thank you, Rachel.
Yeah.
There's a few questions that we've been typing away furiously and answering as many as we can. But there's one there that I think is really, this is always lots of inquiries about this. So I think that we should probably take the time to go over the issue with no non-sexual contact again, Sarah. And we get this question an awful lot, and it's typed in there, like, you know, the issue that if somebody has never had a penetrative sex, the issues surrounding being a virgin or seeing a hymen. I think that's worth revisiting.
Yeah, absolutely. And we know that this can be a very difficult issue and can be sensitive. And we do know that sample takers can be very reluctant, obviously, to examine somebody who hasn't had penetrative sex in the past. Again, it is about that conversation about what do we mean about not having had sex before. So it's for somebody who has never had anything at all up their vagina, they still don't necessarily always have a hymen. So we know a hymen is not a reliable, it's not 100% of women will have hymen, or they might have hymenal remnants. And that is, as I say, if there has never been any, tampon use, any vibrator use, dilator use, anything at all, that doesn't tell you whether or not there's a hymen there. And again, the other thing is that talking about sex is one of those things that some of us are more comfortable with than others. But sitting down and having a conversation with a woman about what she has experienced in terms of sex toy use or anything like that can sometimes be a little bit difficult, but still absolutely worth having. If she is coming to you looking for a screening test, that's probably the first step. And you're saying, okay, if we're doing this and you haven't ever had any penetrative sex, it may be uncomfortable. It may be that I might see some hymen tissue when I go to examine you. Is that okay with you? So she's requested the test. She's coming looking for it. And so you're doing it very much in a shared situation. You're talking about it with her. You're saying, look, I'm going to have a look. I'll see if this is uncomfortable. We can talk about the risk levels and see, what we can do about that. So again, always having that shared conversation. If it's somebody who